Thank you, Jens. Not to belabor the subject, but what we just finished talking about, the birth three-column sort of stuff, Francis came up with that out of, as Jim mentioned, from the cervical spine, but it was definitely from René Louis. He had the cervical fracture system had the anterior part, the lateral pillars, and then the posterior. And so Francis applied that to the thoracolumbar spine. But in actuality, it was in Andrew's home state of Utah, where the original biomechanical studies were done to test that theory, that concluded without a doubt that it was the posterior column, the osteoligamentous aspect back there, that was truly most important in terms of stability. I mean, you can break the bones in front as much as you want, but if the ligaments in the back are intact, then it's a relatively stable situation 9 out of 10 times. So my task was talking about the assessment of the thoracolumbar injuries, and it's obviously in 15 minutes we're not going to cover it all, but we can see that let's see what most, as John pointed out, when we assess the thoracolumbar spine, we're talking about 4 basic or 4.5 basic fractures that can take place. There's the compression type injuries, and then there's the bursting type fractures, which can be divided into stable and unstable, as John pointed out, based on whether the posterior facet ligamentous structures are intact. Then there's fracture dislocations, or there's chance fractures. The TLIX classification system, just like the AO system, is an easy, relatively straightforward way to approach things to decide if the situation that you've been given is a one that might need to be treated operatively or non-operatively. And that's the basic assessment that we are going to be asking of ourselves when confronted with injuries like this, not necessarily the type of brace or the type of bed that they're going to be in, but do we need to do an operation or not? And it is based on those 3 concepts, which was relatively unique in neuroorthopedic spine or musculoskeletal treatment in the first place, because these were the first classifications that went beyond just the bone being broken into the realm of neurology and the ligamentous structures. So you can see now with CT scanning, very subtle injuries here can turn out to be very important things when you add the MRI. So again, in the olden days, all we had basically were X-rays to look at, and classifications came out of that. And then the CT scan in the 80s was added, and then the routine use of MRIs were included starting in the late 1980s and 1990s. So in most people today who are going to take care of fractures that look to be relatively complex on initial assessment, we'll be using at least 2 of these 3 modalities. We don't really use X-rays anymore in the standard trauma setting. And in fact, for the most part, the first X-rays you will probably see will be those at their first follow-up visit when they return from the hospital. So the first thing you'll see will be CT scans, which are just a million X-rays all packed together. But then for a lot of questioning situations, most people are going to add MRI images principally to assess that third and vital posterior osteoligamentous complex. And as was pointed out, flexion distraction injuries of the thoracolumbar spine, like the one we just saw on that MRI, again, as in assessing, remember that many of these people will have injuries to that to the abdominal structures inside. In fact, almost 50% of the time, whether they're 6 months old or they're elderly, people will oftentimes have structural injuries inside the abdomen. And just last week, we took care of a young 31-year-old who was involved in a motor vehicle accident with a thoracolumbar distraction injury down at L4, who had to have a piece of her colon removed because of an injury before we had treated her with an operation. So the TLEX system, again, as John pointed out, is a relatively straightforward, as is the AO, based on points. And if you look at the involvement of those 3 areas, you can add them up and then decide whether to proceed with an operation or not. The simplest end of that arc is obviously the compression fractures, which is a stable situation because only that anterior column is involved, and the osteoligamentous situation is fine, as is the neurology, so they don't need to have an operation. And then you move it up a little bit, and do we have a burst fracture? Should we do an operation or not? But it turns out that if there's no injury to the ligaments in the back and there's no injury to the nerves, they can pretty successfully be treated with an operation, without an operation as well. And these systems do accurately predict treatment. But again, harping back to what John pointed out, it does predict a treatment pretty consistent with the previous recommendations, but there are some outliers there in terms of what do we do when we have more than one level involved, and what do we involve with those extension type injuries that we oftentimes see when the elderly with ankylosed spines fall down and extend their spines too much and it cracks open, or even things like the coronal split A2 fractures that were pointed out. Those fell out of the TLIC system, and thus the AO is a little bit more inclusive. And here's an example, just such, an A2 fracture of the L3 vertebral body, which on MRI has very little in the way of retropulsion of the canal, but you can see the disruption of the two fragments. And as John pointed out, that anterior process will retropulse back a little bit, but in as much as we see is that when you've got the coronal split like this, suddenly, like in some of the chance fractures posteriorly, soft tissue will come in between those two pieces of bone, and that is what is going to prevent real healing and sometimes end up with a situation just like this, possibly requiring revision surgery for the first time, but now more for pain than for neurology. Remember, the area that's most commonly involved with fractures is that thoracolumbar junction because of the transition from the rigid thorax to the lumbar area. But it's the one that has more than higher up fractures in the thoracic spine, the greater chance for instability and thus long-term disability. Fractures down in the lower part of the lumbar spine, much less commonly fractured than we see at the thoracolumbar junction. And these are the ones that are primarily involved with axial loading, such as jumping out of trees or airplanes, that sort of thing. And then when the softer type bone situations, the elderly with osteopenia will tend to more oftentimes fracture down in this area than at the thoracolumbar junction. Because down here, however, there are fewer nerve roots left. You know, most of them have exited the spine and taken off for wherever they're headed in the legs. You don't have as many nerve roots, and thus you have a much lower incidence of neurologic injury in a lot of these fractures. But versus the higher up thoracolumbar regions, the potential for long-term functional disability is going to be a lot higher down with these fractures than the thoracolumbar injuries. So surgery is actually much less common in the lower lumbar injuries, and then when it's done, it's almost always done with posterior short segment instrumentation, although sometimes now with the experience of anterior approaches with access surgery and whatnot, sometimes we can approach some of the lower ones like an L5 fracture like this from an anterior approach if deemed necessary. But here's one that was treated successfully with a brace at this time. And as you can see on the slide on the right, remember that if you are going to treat some of these low lumbar fractures with a brace, most effectively biomechanically speaking, you're going to want to add a leg extension to that brace because of the high riding pelvises you see there. If you're going to control L4-5 with the sacrum, you need something a little more than a TLSO. But my interest in all this came with fractures like this, where this is a forest ranger who fell out of his stand in Minnesota and presented with this plain X-ray on the left, but the CT images on the right. And the question obviously came to our mind, my God, what do we do with this sort of thing? But it turns out this individual, as I suggested on our previous slides, was actually neurologically intact. And when you get down here in this lower lumbar spine, here's a pretty decent representative example of why the people who have injuries way down here can be okay from a nerve standpoint, because there's only a couple nerves left, and they probably go to some corner of this mess right here, find a place to hide out, and keep working. But that was what got me interested in the idea. I mean, should we be operating on these things or should we not? So as Jens pointed out, we looked at a lot of these patients who were being treated in the Minnesota area at that time to see, and we randomized them into a group of whether to do an operation or not. But here, as you can see, on one of the representative examples, a large degree of retropulsion at the L1 vertebral body, but a neurologically intact fracture. And remember, laminar fractures will be seen on just about every CT scan. In fact, I would dare say that a laminar fracture is a critical and inherently aspect of the burst fracture, because it's a rigid ring and you can't break a lifesaver in just one place. So there is going to be a laminar fracture. You may not see it on the CT scan because the cuts may pass over it, or it may have reduced itself so that you can't discern it on the imaging. But you have to fracture the lamina in the back in some form or fashion if you're going to break the front part of that ring. And what we found is that there was no real difference between whether you did an operation for a mechanically stable, neurologically intact burst fracture, but it was a heck of a lot more expensive, and there were a lot more revision surgeries. And then our colleagues just to the north of us in British Columbia looked at the next step was, if you've got the burst fracture like this, maybe we don't even need to wear a brace at all. And it turns out that they randomized the same sort of thing, brace versus no brace. And again, at a year, and then subsequent papers from this group have followed them up at 5 to 10 years and still showed no difference whether you wear a brace or not for a mechanically stable fracture. And I heard John mention just last night that he hasn't put a brace on a lot of these injuries for many, many years, even anticipating what the group here was going to find and print in the publications. And I think probably a stable injury probably works like this one seen recently. And this is a process that is probably may explain to me why non-operative treatment for stable injuries may work, because you can see what happens over time is this growth of bone, because these bones are just like long bones. In other words, when they break, they bleed. And when they bleed, bone-forming cells float out here looking for something to do. And the next thing they'll do is attach onto the bone just above them. And over time, this segment right here, which looks nasty on plain pictures, turns out to be a stable segment of two bones linked to each other with a normal disc below and a normal disc higher up above. And that's probably why non-operative treatment may well be working in lots of these individuals. So when do we have to do surgery for thoracolumbar fractures? Well, in the multi-trauma situation, that's clearly going to be a situation. But again, as John also pointed out, in real-time assessment of these situations, this seminal work from the University of Missouri 30 years ago still and is very, very important when you're deciding how stable a certain situation might be in terms of holding up over time to prevent pain. It's not really important in terms of preserving the neurology, so to speak, but it is very important in terms of maintaining the sagittal stability of the thoracolumbar spine, and especially the pain that goes with it. And the group out of China looked at a big list of burst fractures a few years ago and showed that the loss of the kyphosis correction was significantly correlated to that gains load scoring share. And the way this thing works is you look at how much of that bone is involved with comminution, here how far apart those fragments are from each other like this. Are they well opposed or are they far apart? And then what is that angle right down here? And so if you have more than 6 points out of this scoring system, That was what Rob McLean originally found and showed why short segment doesn't work in these sorts of things. And you need to either go in the front and do support there or do multi-levels in the back. But it turns out if you're going to even try to take care of fractures who have components of this non-operatively, you may find yourself running into trouble with maintaining sagittal alignment if you don't take into careful consideration the degree of comminution and the angulation there, because the people down in Virginia looked at this and showed that all had this group here had low TLIC scores of 2, which would suggest successful non-operative care. But when they looked at them, those with high scores beyond 6 on that McCormick and Gaines score fell into more kyphosis and more stenosis and ultimately ended up in the operating room. And the situation here, the comminuted burst fractures that we see now with CT scanning may actually be the Achilles heel of the original TLIX classification that I showed out earlier. Finally, senile compression fractures or senile burst fractures are also a different kettle of fish here, because they don't have the strong structural support anteriorly, and they may be neurologically intact upon presentation. But what the osteopenic bone of the elderly can tend to do with situations of complete collapse like this is actually move around more and posteriorly than the standard one in, let's say, a 30 or 40-year-old. Somebody younger who has a burst fracture within the thoracolumbar spine can oftentimes be treated, in one way or other, but if they treat it non-operatively, they could be seen back in evaluation within a few weeks or something like that, just for follow-up x-rays. Because if you look at the literature of the burst fractures in this area in terms of how many maybe came back with a neurologic problem, there was really only one in Weinstein's original publication out of Iowa that showed 1 out of 70 people ultimately came back with some L4 radiculopathy that needed some surgical care. But by and large, if you've got a burst fracture within the thoracolumbar spine and you are neurologically intact and you are mechanically sound, it is a stable situation and you are not going to come down with any neurology. An exception may well be, however, the elderly, because this stuff is soft bone and it can move. And what we have seen, unfortunately, that there are some people who will present with neurologic compromise, oftentimes bowel and bladder issues, but it doesn't happen right away. It can happen, as this group out of Maryland showed, maybe multiple weeks after the original onset. So my treatment of an individual who presents with a situation like this, who is neurologically intact, is not to say, come back in 6 weeks. I want to watch them every week or two for the first few visits to make sure they stay neurologically normal and are going to go on in that form and fashion. So I think with that, I will pass. This is an elderly who had that same sort of fracture, and you can see the difference between a CT scan here when they lie down like this, but then when they stand up, you can see collapsing into almost 25 or 30 degrees of kyphosis. All right. For the interest of time, I'll pause at that.
Thank you, Kirk. It's great to hear from the source himself, and I know you have to get into the lab in a second, so we'll have you probably change over and get into the lab. But one big question, are we looking at the correct variables with due diligence necessary? What I mean with, we have a very nice classification system which identifies structural issues, which identifies neurology. You identified and hinted at kinetic energy. Imparted, you identified bone density, but I'll add another variable to that, and that is obesity, large size, braceability. I'll add psychosocial status and wherewithal in terms of handling non-operative care in a constructive fashion. So are we looking at the correct variables? Are there more variables that we should rate higher as we try to classify injuries?
Well, I would agree with exactly as you finished up your question there. I think there are a lot of variables. many, 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 and that's probably where the art of our science still remains in place. Yes, I glossed over it and didn't really mention it, but obesity probably plays a role because, as you know, from a biomechanical standpoint, any external orthosis only works as close as it can get to the bone. And if my external orthosis is out here in a different county from the spine, it's probably not going to exert much mechanical stability. But braces, as we know, don't really add much anyway, even on the thin people. If it's going to kyphose, it's going to kyphose. A brace may make it less painful as it does so, but it's going to kyphose. But age, activity expectations, other injuries, many, many things play a role. I think, as John pointed out, the AO classification didn't really get into, but it does really predict, as he suggested in the earlier slides, not only should you do an operation or not, but maybe what kind of operation. Do you go in the front or do you do it in the back? That was borne out in the TLIX classification as well originally. So I guess my point is, I think a lot of what we've talked about in these first two lectures give you a platform on which to begin your analysis and then some of your treatment. But ultimately, there still remains a lot of variability in people and injuries and expectations that we do still need to handle on a case-by-case basis, but hopefully with sound clinical and biomechanical principles at our behest. John.
Yeah, I'd echo all of that. The obese patient, for example, you may have a burst fracture, the type B fracture you feel you need to fix. In a thinner patient, you may be able to do a short segment. In the bigger patient, you may opt to do 2 above, 2 below, longer segment to resist the forces. Once their belly gets out here, they're just pulling over into kyphosis. And so those factors, no question, come into play in your decision making.
And there's no black and white. I mean, I personally have seen not a number, but a handful of individuals who have came in with clear B fractures, with torn posterior osteoligamentous injuries. And I can still put my finger in that gap in the back where the spine is bent like this, but they have no pain and they're functioning well. So I'm not dragging them into the operating room. But so, still take everything on a case-by-case basis.
The other thing I would add is it's interesting that we base all this on CT, but the plain X-ray, is sort of what we do to follow the non-operative ones in reality. So anybody I'm treating non-operatively, I always get a standing film because Kirk shows how nicely the supine to stand's very different. So before they leave, I always have a standing film, and we follow them on the standing film. I mean, that's what we use. So the X-rays almost give us our baseline to then follow the non-operative treatment of the fracture. It doesn't, it's not as critical in decision making.
Yeah, a lot of people would take that standing X-ray before they left the hospital and then see that and say, whoop, nope, sorry, you're not leaving. You're going to get an operation. But not everybody necessarily needs it. And there's plenty of people, probably a little bit older, with less demands on their spine, who can settle into a kyphotic deformity and still function just fine.
I have one question from the chat room. There are several, but thank you all for your interest in participating online. I'm going to give the online people a voice. This fracture here with air in there, is that a role for a vertebroplasty? This is a low energy situation. Would you put a vertebroplasty or kyphoplasty in some form of cement?
Again, I do kyphoplasty, not on a daily basis, but my assessment of this particular injury was that even blowing up the balloon with that much air and those many cracks in both superior and that I was going to expect that when I injected the cement, it was going to go everywhere. So I chose not to do that. And this woman actually did go on to have a 4-level of thoracolumbar fusion because she was elderly, from T10 down to L2 for stabilization purposes.
And I defer also to our session 5, which specifically talks about osteopenic fractures with Dr. Schauner, Dr. France, and Dr. Schnake arguing these points in greater detail. So thank you for the question. Thank you for a great lecture. So we'll have you get changed for the lab, and Gary is waiting for you, and we'll ask Dr. France and Dr. Daly maybe to come up front and Dr. Davis has a case so we can kind of illustrate what we're talking about. So thank you to our online guests for their thoughts. And while Dr. Davis is getting ready, I'm going to run back to a colleague from Harborview. Tell us who you are and what you are taught to use to communicate fractures amongst one another when you call Dr. Bellbarber or Dr. Bransford at 2 in the morning.
Thank you, Dr. Chapman. My name is Eric Newman. I'm one of the fellows at Harborview currently. And we do like to use the AO classification for discussing fractures and operative treatment, non-operative treatment decisions. I think it's a good classification, like Dr. Francis' lecture alluded to. It's clear communication between providers, and I think it also helps drive our decision-making processes.
I'll run up to a colleague and introduce yourself again. He's from UCSD. You're in academic practice. You have a wide fracture catchment basis in San Diego. What do you teach? What do you use? What do you want to hear when you communicate with others?
Yeah, I think we probably use a bit of a hybrid of both. So I think AO is pretty reliably used, but in terms of decision-making and treatment, I think we kind of default back to TLIX.
So you want to score. TLIX is not a classification, but a score. So for our two panelists, Dr. Daly and Dr. France, we have a case, and this is Dr. Davis. He's going to briefly present a recent case. Are we good to go?
Yeah,
go ahead.
We're good to go. All right. Thank you. Case 1. This is a man in his 60s, pretty healthy, who has this L1 AO type A4 burst fracture, who was admitted to an outside hospital. This was his imaging upon presentation and evaluation by this facility.
So, Dr. Daly, as co-chair, you've been remarkably quiet, and that means I've babbled too much. So, and at the University of Utah, what do you want your neurosurgeon ortho colleagues to tell you when they call you in the middle of the night as this man has finally gone through the trials and tribulations of the ER?
Well, we'll use the AO classification to get some sort of basis, like you say, an A4 fracture. So that puts me in the game a little bit. But then you want to know neurology and so forth in this guy. And I recall he was neuro-intact. You said that, or have you gotten that far?
Yes, sir.
Okay, so those are the things that I want to know. And so I think you have a lot of leeway here with what you can do with this. The thing that we talked about before is what sort of patient this is. And that's difficult to get in a classification system. Because if this is somebody who's going to have a hard time mobilizing, he's, kind of rotund, a little bit obese or something like that, and he's not that strong a protoplasm, then I would certainly err more on the side of surgical intervention in this at this situation.
I think the other issue you have to determine is, in this patient, the key is this going to be stable? Because that alignment's fine, and you can let it heal there. It's going to be stable or unstable. And I think there's, what we look at in turn is the posterior ligamentous complex. And I think there's a couple ways I look at assessing that. If I look at the CT scan, I don't see anything destroyed posteriorly, no gap in the facets, and I'm pretty confident it's going to be stable. I just get a standing x-ray, because really that's what I care about, is how it looks standing. So I don't bother with an MRI. I just get a standing x-ray, and I make my decision off of that and follow the standing x-ray. If I'm pretty sure it's disrupted, yes, I can see gapping in the facets. Frankly, I don't often even get an MRI. I'm just going to fix that. It's the ones in between where I think maybe the spinous processes are a little wide. I'm not sure. I think it's disrupted. I think this is going to fall for me in an operative category. I will MRI that one to make my decision. Because if it looks clearly disrupted on the MRI, I'm going to the OR. If it looks not disrupted, I'll probably get a standing film. So my timing of the standing film can vary a little bit depending on my suspicion.
Dr. Harrop. Sorry, Dr. Harrop. has-
Go ahead, Andy.
No, we've talked about this earlier. I think one thing that's confusing to me still is when to get an MRI. And I try to default to get an MRI in most people. And it's helped me out considerably in a number of occasions. First of all, not only just looking at the posterior ligamentous complex, but also looking at the conus and any pathology that you might see in the conus. Because even though this is not that displaced a burst fracture, I have seen, basically high cord signal and so forth in people who are asymptomatic until you followed them out for a couple of months and they were still having trouble with bladder. And I think it's really helped you sort of notify and educate the patient and educate us.
So I'm actually going to change something that's kind of very interesting. I think classification systems are great for teaching. A lot of fractures are pattern recognition. So you look at the room, you go, oh my God, I know what that is or whatever because I've seen it. You have to learn it. So love classification systems for education. Number two, I think they're great for registries. But your question was very interesting because I don't think it's true anymore. My residents never called me and say, "Hey, he's got a L3, AOB2," because what happens is in reality, either I pull it up on my PAC system, or they'll take the camera, they'll videotape the PAC system and say, "Hey, Mr. Smith came in here with this fracture." So I just want to. Has that changed the way your practice has been? Because Jens asked the question, and when we grew up, it was a different world.
Yeah. Oh, yeah. Yeah. They call you on the phone and do exactly that. And I think it hurts because I think it does hurt their ability to recognize patterns because it is pattern recognition. Like we can sometimes sniff something out. Like if I get a fracture and it's in thoracic level and it doesn't look too bad, but I see multiple rib fractures around it, or I see a sternal fracture and it looks like just a compression, my antenna goes up because I'm thinking there was a lot more injury and severity imparted on that injury, and I may say this needs MRIs, this needs to be dealt with because it's pattern recognition. And I think you're right. I mean, they then can forgo that step where they have actually made the decision about what it is, and they just show it to you and let you make the decision. Other than Newman, who was my resident, he always had the pattern recognition down.
So one question I have is then, are we safe from ChatGPT and some machine learning algorithm to tell us what fractures and what we should do, Andrew?
Yeah, I think we're very safe from that because again, they haven't met the patient, and I think this is very key. And I try to involve, and one of the reasons that I get as much information as I do is to try to involve the patient in the decision-making process. I really try to make them a participant in this instead of telling them, oh, you're going to get screws, you're going to get rods, you're going to whatever.
Great segue,
Man, that's
Dr.
great.
Davis. Can't be teed up better.
And I think
Patient decision making.
And I try to predict when Dr. Chapman will have comments and put these pause thoughts slides in. So we are in a good place. This gentleman is, to your point about the patient, he's very well educated and has family members in the healthcare field who are very involved in his current care. Would you like me to discuss or
go for it?
Okay, so the anecdote provided by the patient's family and the sister, I believe, sister or wife who is a physician, is that the spine surgeon on call came into the patient room and said, "Oh, I have block time tomorrow. Let's go ahead and get you in and fix this." And so the patient was understandably wary of this and reached out to one of our colleagues.
So does that meet the algorithmic decision-making, Dr. France, you have, or availability, might as well fix it?
Yeah.
Does that enter your mind?
I wish we would say we never think like that. It does make it easier, but I think there are certain fractures that we should say you shouldn't have surgery, and there are certain ones we say you should. But like this fracture, I think you can involve them, and it obviously is a discussion on what's good and bad about fixing it. You can harm them more fixing them, but sometimes you can also help them. So I think like this is a good one. This has to be a discussion of the pluses and minuses and a real discussion with patients.
And I hope Dr. Wood, as he's getting ready for a surgical lab, can hear us. Dr. Daly, you have the microphone. Would you fix this? Do you want to go back one slide?
Again, after talking to the patient,
You have overtime.
Yeah, I know it's good, and I may not later in the week, but I have a sense in this gentleman that he's probably pretty active,
Yes.
and I would err on the side of internal bracing. In other words, fixating this with a level above, a level below, and a screw at the index level. That would be one of I would think in those terms.
Dr. Harrop, we need a neurosurgical advice again. This looks pretty tight. This is T12, right?
Oh, there's not a shot in hell I'm operating on this guy.
There's not a what? Speak close to the microphone.
I said I'm not operating on this. This guy's getting standing upright X-rays, seeing if he moves. And the other thing is the patient was in a lot of pain, so I operated on him. That's the other thing that's completely irrational to me.
Yeah.
I mean, get the person up. If you want to put them in a brace, I do think, at least in the Philadelphia area, people feel better because they feel like they're being treated rather when you say, hey, just get up. The Canadian study showed this is an A3 fracture. You don't need a brace. In my patients, I think, they do like the brace, and maybe that's...
Yeah, I think I'd never use braces. If I have a patient that's telling me, I'm having a lot of pain, I said, I can put a brace on you. You can see if you like it. Quite frankly, even those patients, usually by a couple weeks, they're not wearing their brace. But I do use them occasionally, and I would non-operatives too. I would get a standing film, follow them closely. And, if they collapse too far, I would come back. You have to follow them closely enough that your operation, if they fail, is the same as the one in the beginning. So if you don't follow them close enough and they get 6 weeks out, 3 months out, then your operation changes and it becomes bigger. So you want to follow them early. Most of the collapse occurs in the first 2 weeks.
Dr. Kazemi, you're going to talk about some absolutely cool state-of-the-art prone corpectomies, percutaneous fixation later in the day. We're looking forward to your lab. This is a very active guy.
No.
No? You have overtime. No. You have overtime.
No. I just think John's last comment was on the money. Why fix them if it's going to cause more problems for the patient, and then ultimately for you, they'll be complaining of pain. They'll be calling your nurse. In this situation, I think that this patient will fuse, and he's still young, pending no osteoporotic issues.
Thank you for that, by the way.
No, well, he is. In this day and age, 60 is very young. And the other aspect about it is that we can, with close follow-up, we can change our treatment plan if we need to.
So just...
Sorry, Micah Blaze is my name. I was just when you say you would follow this patient and see them at 1 week or 2 week, what would be an acceptable versus an unacceptable amount of kyphosis that develops?
So if they stay under 25 degrees, I'm probably not operating on them. If they get into the 25 to 30 degree range, I'm going to start having conversation with them. It starts to become a mutual decision. If they get above 30, I'm going to nudge them towards surgery. And that's kind of vague, but there is some longitudinal studies out of Iowa that showed that once they got above about 30 degrees, they tended to have more late pain. It's not like they all did. In fact, some people at 20 degrees have late pain, but they tended to have more. So I might nudge them at 30. 25 to 30, I'm going to have a long discussion. Under 25, I'm going to encourage them to not do it. And I agree with Jim. I don't go by pain. I mobilize them. There are times pain has a factor, but usually when they're having excessive pain, it's not as much the fracture as it is their ability to tolerate pain. And so I'm very leery of using pain as a determining factor, although I think you have to take it into account.
So, go ahead. I was going to say, I wish Kirk was here. There's 3 prospective randomized studies that showed surgery kyphosis versus non-operative were the same. So it's very interesting. Everyone's like, I'm going to operate on them so their kyphosis doesn't. But if you look at the prospective studies, guess what? We didn't do great surgically fixing their kyphosis.
Yeah, I think this guy will be the same in a year, whether you operate or don't operate.
What are your thoughts on use of, not for this patient, but in general, we talked about yesterday about bracing and thoughts of use on internal bracing, but taking it out later, so removal of hardware, so keeping the joints mobile. And the second question would be use of ALL for ligamentastasis, for distracting the pedicle screws and getting good correction, and then letting go later.
So I think and I'm going to show some data on MIS for burst fractures. And so if you treat a minor burst fracture with little kyphosis and you correct them 5 degrees and take it out, you end up with the same thing you would have had if you never fixed them in the first place, in most studies. I think if you want to get correction on a burst alignment and hold it reliably, you got to go 2 above and 2 below. I think if you do short segment, you can hold most fractures. It depends on fracture, patient size. You tend to get a little bit of settling. It may have not settled as much as it would have without surgery. So I don't think there's any value in correcting 10, 15 degrees, take your hardware out and let it settle back 10 degrees. So I think it's 2 operations to get in the end what you'd have gotten with surgery. So the concept of internal bracing. Now, what we don't know is with all the alignment. One, a thoracolumbar junction, you can tolerate a fair amount of kyphosis because you can compensate below and above. Does that compensation with hyperlordosis over time create problems? I have had patients who are this age who became symptomatic from their lumbar stenosis after a fracture that I think probably is because they're hyperlordosing more. So I think it has some effect.
Jim, and then I want to ask Dr. Schonert what he
I
thinks.
actually just have one quick comment. Can you go back to the CAT scan, because this gets said all the time. This guy's got a laminar fracture, and that people always comment, number one, that's a 3-column injury, which it's not. And number 2 is Camisa, when he was Frank Eismont's fellow, wrote up a paper, which is very interesting, that said that 30% of these patients have an entrapped nerve root.
If they also have a deficit, though.
Yeah.
If they have a deficit also.
I personally have never seen that. And so if the patient has a radiculopathy, I might go in and do it, but I would never say, okay, I'm going to go in and operate on them if they didn't have a deficit.
Neil, I don't know what you heard. Dr. Schonert has a unique background, trained at UCSF and went to Thomas Jefferson for a fellowship. So he has a bicoastal education, and it's been a great partner here in the Puget Sound area in Washington State. I'm confused now. I heard treat, not treat, brace, no brace, percutaneous, a little here, a little jacking up there. What am I supposed to hear? Give us a consensus.
So the part that I loved about this is that someone was willing to see this patient back and follow up and follow them closely, because I do that for all my vertebral compression fractures, young and old. And when settling occurs in the first, second week, I know that patient has the opportunity to go on, if they're osteoporotic, to vertebral plana, and you have a disaster on your hands. In this setting, it looks like if you did the Hounsfield units on this person is probably in the mid-120s, maybe 130. So the risk of that is low. So I'm biased toward observation and not operation.
All right.
We need to get into the lab. Gary has given me the hint to move.
So at this point, they sought our second opinion. An off-the-shelf TLSO is given with the advice that if you can get up, you can safely leave the hospital. And then this was a little bit uncomfortable for him, had a little bit of a belly, otherwise very healthy, and a custom TLSO fit the patient quite comfortably, and the patient did very well.
Do you have the final? Yeah, we'll stop there. Do you have the final image?
This actually is the final image.
Okay,
right here.
So he actually did very well. I got to see this patient. He discharged himself. Basically, he and his wife dictated care. He said, "I want a brace." The initial brace didn't fit quite well because he had a little bit of a belly. Who am I to speak? But it was a little bit more pronounced than mine. Even so, we saw him in clinic. He kind of schlepped himself in. This is one more final question before we go into the lab. Andrew, how long does it take for these non-surgically treated patients to get better? This guy came to us in clinic and he was suffering. He was neurologically normal, as Dave identified, but he was suffering, and that brace didn't fit well. We actually sent him for a custom-made brace. That's not inexpensive. It was like $3,500 for these custom-made braces these days. But with that, he got better. But what's the expected time frame when a patient can feel more comfortable?
I would tell them and counsel them to be patient if he's chosen this pathway, to be conservative for 3 to 6 months. And I tell all my trauma patients, they're different in the second year than they were in the first year, that there is light at the end of the tunnel, that they'll feel better down the road. And I've noticed that over the years. And there's no data to support it, but it just takes longer for these patients to heal than it would for, an L4-5 interbody fusion.
That's a wise word. Gary is here again. We are ready to go into the lab. Thank you for a great session. Thank you, Dave.